hepatitis and HIV virus. Pyogenic means there is a streptococcal, staphylococcal, most commonly pneumococcal. Sometimes there is a chlamydia infection or legionella. So patients of these patients having a presentation of infectious causes have a history of the fever. There may be a chronic history like a 15 to 20 days of fever, or there may be sudden onset 3 to 4 days of fever. Along with this, there is a chest pain. So if these patients having history with the chest pain with fever, always go for echocardiogram. And tuberculosis, that is a most common cause of pericarditis in India. Fungal, and usually in immunocompromised patients, the fungal may cause pericarditis, usually in HIV, hepatitis B, or chronic autoimmune disease in the form of histoplasmosis, candidate blastopneumococcal, and other infections like syphilis and parasitic infections may cause. In the non-infectious pericarditis, there is a idiopathic that cause is unknown. Renal failure, the chronic renal failure only, there may be pericarditis. And neoplasia, sometimes in malignancy, may present with the pericarditis in the primary cause, or there may be metastatic lesions. Metastatic lesion, that is important because sometimes patient may present with the clinical feature of pericarditis only. Then you have to search out the primary cause for the malignancy, because patient may have a transitive pericardial effusion acutely developed. So these patients present with a sometimes sudden onset of the chest pain, and these patients have a metastatic lesion in the lungs and breast cancer, most commonly, and rarely in the lymphoma and leukemias. Sometimes in the trauma, penetrating types of or non-penetrating type chest pain, trauma, most commonly in the penetrating chest, what causes acute pericarditis in the form of acute pericardial effusion. Myocardial infection, that is known as Dressler syndrome. Post-radiation after malignancies, familial malignant fever rarely causes, and the pericarditis resembling to with autoimmune disease or with hypersensitivity reactions causing the pericarditis. In these segment, most commonly there is a rheumatic fever, collagen vascular disease, SLE, rheumatoid arthritis, ankylosing spondylitis, granulomatous disease with cholangitis like Meissner's disease. All these may cause acute pericarditis. And drug-induced, that is important. Some drugs, that is definitive drugs like phenytoin, isoniazid, that is commonly used in the ATT. Anticoagulants, methacilinides, hydralazine, propanamide, but most commonly we use phenytoin, isoniazid, and anticoagulants. So patients in anti-epileptic drugs in the phenytoin coming to you with an emergency with severe chest pain, always suspect pericarditis. Patient having an ATT, isoniazid, and anticoagulants, but anticoagulants usually cause hemorrhagic type of pericarditis, that is rare. Post-cardiac injuries like cardiac surgeries after myocardial infarction, these also causes pericarditis. So, by far the most common pathological process involving the pericardium causing acute pericarditis, having all type of etiologically pericarditis. Similarity in the chest clinical features: first, chest pain, pericardial friction drop, ECG changes, and pericardial effusion. So patient coming to you with chest pain, if you palpate there is a friction drop, and the auscultation there is a sounds, go for ECG. If ECG also suggestive of changes of pericarditis, immediately go for 2D echo. So chest pain, it is usually present in acute infectious pericarditis, and in many cases of another hand, hypersensitivity and autoimmune causes, chest pain is seen. Rather than malignancy, non-infectious causes, non-infectious causes, pain of acute pericarditis is often severe. That is a retrosternal chest pain, and the left precordial region is referred to the neck, arm, or left shoulder, that is simulating with the acute myocardial infarction. Pain type of character is a pleuritic type pain, and consequently to accompanying pleural inflammation also, it's a sharp aggravating inspiration and on increase on coughing. But is sometimes it is steady and radiate to the trapezius ridge in the back wall and in the arm, like myocardial infarction. So there is a confusion with acute myocardial infarction that is common with the acute pericarditis. How will you differentiate between two? So a patient is an acute pericarditis or myocardial infarction. Acute pericarditis pain is increased on lying supine position, and there is a relieving with the sitting or the leaning forward. While there is an acute myocardial infarction, there is no change in the posture. Second, we have to go for the enzymes levels. Enzymes levels definitely is increased in the myocardial infarction. And the third, ECG. ECG have a definitive changes in the acute myocardial infarction, but there is a peculiarity in the pericarditis. So, by these three, we can distinguish between two. Second, there is a pericardial friction rub that is audible at some point in the illness in the about 85% patient of the acute pericarditis due to the friction of the two layers. It may have up to 3 components per cardiac cycle, and it is a rasping, scratching sound, or grating sound. That is a typical rasping in character, or scratching or grating in nature. Most frequently at the expiration, when patient is leaning forward in an upright posture. So we can distinguish between there is a heart sound, there is a 3 extra sounds in the form of pericardial friction rub. ECG changes in acute pericarditis without massive infusion usually display changes secondary to the acute subepicardial inflammation. That is the changes in the ECG. When we ask the questions why there is a changes in the ECG in the acute pericarditis, because there is subepicardial inflammation. Inflammation causes changes in the ECG. It is involved in the 4 stages. First stage, there is a widespread elevation of the ST segment. ST segment is also elevated in the myocardial infarction, but there is a difference between two. There is upward concavity, like this. In the pericarditis, in the myocardial infarction, like this, that is the convexity. So it is a upward concavity involving 2 or 3 standard constitution leads in the V2 to V6 or the limb leads, with reciprocal changes in the other leads, or only AVR and V1. There is a depression, ST segment depression. So there is a depression of the PR segment below the TP segment, reflecting atrial involvement. If there is a depression of the PR segment, that reflects that there is a atria is involved. If there is a ST segment, that is involvement of the ventricles. So usually there are no significant changes in the QRS complex. QRS complex is usually normal. There is no widening of the QRS complex until unless there is a large pericardial effusion is developed. That is a massive, that is known as cardiac tamponade. After several days or few weeks, there is a ST segment return to normal from concavity. That is a stage 2. And only some cases there is a even later T waves become inverted like a myocardial infarction. That is a stage 3. And weeks or month after this, ECG completely normalized. That is a stage 4. Pericardial effusion, that is usually associated with the pain or ECG changes. If the effusion is large, there is electrical alternance. If there is a mild to moderate pericardial effusion, there is a ST segment changes only. If there is a effusion is large or massive, there is a widening of QRS complex, and there is electrical alternance. There is one is normal, another is widening. QRS complex is widened and then normal. That is the electrical alternance in the ECG. Pericardial effusion is especially important clinically when it develops within a relatively short period, because it only leads to cardiac tamponades. Because within a few days, pericardial effusion is developed, it leads to cardiac tamponades. Differentiation from cardiac enlargement on physical examination may be difficult, but heart sound may be fainter with large pericardial effusion. Large pericardial effusion, the heart sound may become dull, or they may be distant. That shows there may be pericardial effusion. If sometimes patient have a suspecting with pericardial effusion, friction rub that affects his impulse and can disappear. If there is a large pericardial effusion, base of the left lung may be compressed by the pericardial fluid producing Ewart sign. Now questions come to what is Ewart sign? Because there is a large pericardial effusion, so it's causing compression of the left lung at the site of the pericardial effusion. So there is a bronchial breathing sounds comes in the back of this infrascapular area. That is known as Ewart sound. Or vocal fermitus get increased at that site because there is a bronchial breathing sound. So vocal fermitus at that site get increased. That is known as Ewart sign. In the chest, there is a typical pattern of the X-ray chest. if there is a large pericardial effusion in the acute pericarditis, so it is a water bottle configuration and the cardiac solute is increased. When you diagnose a case of acute pericarditis, so we have a modality with the echo or CT or MRI, but clinical suspicion is important, so go for the thorough clinical history and examination. If you are suspecting, go for echo. Echo is used imaging technique for the sensitive, specific, and simple and non-invasive test. And the 2D echo, estimation quantity of pericardial fluid, and the presence of recorded by the 2D echo. And that sometimes we use transthoracic echocardiogram. If we are suspecting pericardial fluid and not diagnosed by the echo, we can go for the CT or MRI. That also indicate about the pericardial thickening, the estimation of pericardial thickening, and identify if there is a masses in the pericardial. How will you treat in acute pericarditis? So acute pericarditis usually resolve spontaneously. Most of the cases, there is no specific therapy, but bed rest is important because sometimes patient may suddenly go in the cardiac tamponades. So bed rest is allowed for all the patients who are having acute pericarditis. The treatment-wise, there is a 3-4 treatment is nowadays used: anti-inflammatory drugs, aspirin, steroid, and colchicine. So anti-inflammatory treatments, there is a aspirin 2 to 4 grams per day according to weight, and then NSAID. In the NSAID, the ibuprofen is indomethacin. Indomethacin is nowadays used as an acute pericarditis treatment. If there is a response, these dose should be continued for the 1 to 2 weeks and then tapered off. If sometimes patient is not responding with the anti-aspirin or the NSAID drugs, we have to go for the colchicine in the doses of 0.5 milligram QID. And if the patient is a weight of 70 kilogram, and it can be administered up to 3 weeks, but there is chances of the recurrence is same with the colchicine, but there is a reduced chances of the recurrence with the colchicine, but the chances of infection is more because there is immunosuppressive drug also. Glucocorticoids in the prednisolone 1 milligrams per kilogram dosing. In the clinical manifestation of acute pericarditis in patients who have failed therapy with and do not tolerate the NSAID and aspirin or colchicine, use the glucocorticoids. So glucocorticoids are the sparing drugs. Anticoagulants should not be used because it may lead to hemorrhagic type of pericarditis. In patients who have a multiple and frequent and disabling recurrence with all the 3 modalities, we have to go for the azathioprine or anakinra, IL-1 V receptor antagonist. These are the immunosuppressant drugs, and if sometimes patient use pericardial stripping is required, and the majority of patient acute pericarditis can be managed with either outpatient in the care follow-up. But sometimes patient has high-grade fever, autoimmunity, cardiac tamponades in the large pericardial effusion, and suspecting of the tuberculous type of the pericarditis or some malignancy is suspecting. So all these patients should only be admitted. Otherwise, acute infectious causes or some idiopathic causes should not be advisable to the admission in the hospital, but outpatient can be treated.